Welcome to the Pediatric Systematic Assessment video. In this course, we'll focus on evaluating your patient, identifying the presenting problem, and providing appropriate interventions. Once interventions have been performed, repeat the process by re-evaluating the patient and identifying if the problem has resolved or worsened. Then, apply additional interventions as appropriate. The first step in the systematic approach is the initial impression. It's what you first see and hear when you immediately encounter the child before you touch the child. You'll quickly observe the child's appearance, breathing, and circulation. This will determine your next actions. The Pediatric Assessment Triangle, or PAT, is a memory aid to help you recall the components of the initial across-the-room assessment.
The first thing you'll observe is the child's appearance. This includes his level of consciousness and ability to interact. If the child's unresponsive, you should shout for nearby help and then activate the emergency response system. Then you should check breathing and pulse and provide rescue breathing or CPR if needed. The next part of the pediatric assessment triangle is evaluation of work of breathing. Is there an increase or decrease in rate or effort? Is it normal? Or are there audible respiratory sounds? After breathing, you want to look at circulation, which will tell you how well the child is perfusing. This includes skin color and pattern or obvious significant bleeding. Always remember, it's a life-threatening condition if the child is unresponsive or apneic, has inadequate or labored breathing, or is mottled, gray, pale, or cyanotic. You'd want to immediately call for help and begin life-saving treatment.
If there's no life-threatening condition, you'll proceed with the primary assessment. Now that we've practiced the initial impression, let's move on to the primary assessment. This is a rapid, hands-on ABCDE assessment. You will assess the child's airway, breathing, circulation, disability, and exposure. We'll start with the airway and breathing sections of the primary assessment.
Now, the first thing you want to do is determine if the upper airway is patent and maintainable. Maintainable means that the airway can be kept patent or maintained with simple measures like positioning, suctioning, or insertion of an oropharyngeal airway, or an OPA. Now, in an unresponsive child, open the airway by using the head tilt chin lift maneuver. You place one hand on the child's forehead and push with your palm to tilt the head back. At the same time, place the fingers of the other hand under the bony part of the lower jaw near the chin. You lift the jaw to bring the chin forward. This will lift the child's tongue, relieving a possible airway obstruction. Do not use your thumb to lift the chin, and do not press deeply into the soft tissue under the chin because this might block the airway.
If the airway is not patent or cannot be made patent by using simple maneuvers, insertion of an advanced airway is needed.
If you recognize that the airway is patent, assess breathing. And to do that, you need to evaluate several aspects of the child's respiratory function. Is his breathing pattern regular? What about the respiratory rate? Is that normal for his age? If not, is it too fast or too slow? What about the child's effort? Is that normal? Are there signs of increased effort, such as nasal flaring, head bobbing, chest retractions, or seesaw respirations? And if you see any of these signs of increased effort, do they occur during inspiration, expiration, or both? Do you hear any grossly audible sounds, such as stridor, barking cough, or snoring? Is he grunting? You have to make sure to take all of these into consideration.
When checking a child's breathing, one of the key things you want to assess is chest expansion. Look for chest rise and fall with respirations. Chest expansion should be equal on both sides. Also look for prolonged inspiration and prolonged expiration. This is the time it takes the child to exhale. It typically represents lower airway obstruction, such as seen with asthma.
Now, using a stethoscope, listen to the following areas: front of the chest, just to the left and right of the sternum, under each axilla, and both sides of the back. Is the air movement normal or decreased? Compare breath sounds on the left side to those on the right, and compare sounds in the front to those in the back. Listen for abnormal sounds, such as wheezes or crackles, and determine if air movement is normal, decreased, or unequal. Here's a clip of a real patient in respiratory distress. Note the expiratory wheezes along with a rapid respiratory rate and increased respiratory effort. This child with asthma has an increased respiratory rate and effort, as well as a prolonged expiratory time.
Pulse oximetry generally gives an accurate estimate of hemoglobin oxygen saturation. but does not provide evidence of oxygen delivery. It also does not provide information about carbon dioxide elimination, which is referred to as ventilation. Now, during shock and cardiac arrest, systemic blood flow is severely compromised, and for a pulse oximeter to calculate the hemoglobin saturation with oxygen, it needs to detect pulsatile blood flow. If the child's pulses are extremely weak, the pulse oximeter may not be able to detect the hemoglobin saturation, or the results may be inaccurate. Now remember, your focus should be on supporting and treating the child, not the device. If the oxygen saturation is less than 94% when the child is breathing room air, this indicates hypoxemia.
If a child is in respiratory distress, identify whether it's mild or severe. The following signs indicate that the child is in severe distress and may progress to respiratory failure, so the child requires immediate care. Decreased level of consciousness, very rapid or inadequate respiratory rate, significantly increased or inadequate respiratory effort, and low oxygen saturation or cyanosis, despite high concentration oxygen. Children with respiratory distress usually have an increased pulse rate. If a child in respiratory failure develops bradycardia, this is a sign of impending cardiac arrest. Call for help immediately. Then open the airway. Be prepared to provide bag mask ventilation.
Now that we've discussed airway and breathing, let's discuss CDE, the circulation, disability, and exposure components of the primary assessment. To assess circulation, you'll check the heart rate and rhythm, pulses, capillary refill time, skin color and temperature, and blood pressure.
The assessment of heart rate is very important when evaluating a child's circulation. Alterations in a child's heart rate can provide significant clues to the severity of illness or injury and response to treatment. Age and a number of clinical conditions can affect a child's heart rate. When evaluating the heart rate, first consider if it's normal for age. Anxiety, pain, agitation, or fever can all increase the heart rate above normal. If the heart rate is less than 60 beats per minute with signs of poor perfusion, despite adequate oxygenation and ventilation, you must provide CPR immediately. Feel the central pulses, such as the carotid or femoral in a child, or brachial in an infant. Also feel the peripheral pulses, such as the radial pulse. Another sign of poor perfusion may be capillary refill. Normal capillary refill time is 2 seconds or less. However, delayed capillary refill time is not always abnormal. Other important assessments of perfusion include skin color and temperature. Look to see if the skin is pale or mottled. Note if the skin is warm or cool. Look for cyanosis in the skin, nail beds, and mucous membranes. And compare the color and palpable temperature of the trunk with the color and temperature of the extremities. When the child develops poor perfusion, the hands and feet may become much cooler than the trunk.
The final component of circulation assessment is blood pressure. When you're measuring the blood pressure, the length of the cuff should extend to cover at least 50 to 70% of the upper arm, from the axilla to the antecubital fossa. In addition, the bladder inside the cuff should not cover more than about 40% of the mid-upper arm circumference. A cuff that is too large will give falsely low values, and a cuff that is too small will give falsely high values. Note if the systolic blood pressure is normal or abnormal for children aged 1 to 10 years based on the following formula. A normal systolic blood pressure for children 1 to 10 years of age is about 90 millimeters of mercury plus 2 times the child's age in years. Hypotension for children 1 to 10 years of age is a systolic blood pressure of less than 70 millimeters of mercury plus 2 times the age in years. If you cannot palpate distal pulses, the automated blood pressure device may not accurately measure the blood pressure. In addition, automated blood pressure cuffs may provide inaccurately high readings when the child is in shock. For this reason, if the child is in shock, an arterial catheter is often inserted to enable monitoring of the child's intra-arterial pressure. This intra-arterial pressure measurement should be very accurate if the system is properly set up and the catheter is patent.
It's important to know that children can be in shock but still have a normal blood pressure. Hypotension is usually a late sign of shock, so you want to intervene well in advance of this. Otherwise, they deteriorate very rapidly. It's scary how quickly it can happen.
Now that we've discussed circulation, let's move on to the next step of the primary assessment, disability. This entails assessing the child's level of consciousness, pupillary responses, and glucose.
To assess a child's level of consciousness, we use the AVPU, or AVPU, Pediatric Response Scale. This is a mnemonic you can refer to when assessing a child's level of alertness and response to stimuli. Is the child alert, responsive to voice, only responsive to pain, or unresponsive? If the child does not respond to voice, assess the child's response to a painful stimulus, such as a sternal rub. Two other quick assessments are pupillary response and glucose level. When performing a pupil check, you'll check for size, symmetry, and reaction to light. Unequal pupils may suggest a serious problem, such as increased intracranial pressure or an eye injury. Normally, the pupils rapidly constrict in response to light. In addition, if you shine a light into one eye, the other eye should normally constrict, and this is called consensual constriction. Slow constriction or no constriction may indicate increased intracranial pressure. If one or both pupils are dilated, particularly if they don't react to light, the child may have a severe and life-threatening increase in intracranial pressure and require immediate evaluation and treatment.
For any seriously ill child, you should obtain a point-of-care glucose level concentration as soon as possible to evaluate for the presence of hypoglycemia and hyperglycemia. Neonates should have a blood glucose concentration of at least 45 milligrams per deciliter. Infants and older children should have a blood glucose concentration of at least 60 milligrams per deciliter.
Now, let's move on to the final step of the primary assessment, exposure. This component focuses on monitoring the child's temperature and examining the skin for evidence of injury, bleeding, or rashes.
When you're performing the exposure part of the primary assessment, you perform a complete head-to-toe visual examination of the skin and body, including the patient's back and perineal area. You should look for evidence of trauma, such as bleeding, burns, bruising, or other types of injuries. Also, look for the presence of any type of discoloration or rash, such as petechiae or purpura, which are non-blanching purple discolorations in the skin caused by bleeding from capillaries and small vessels. Check the child's temperature. Note if the temperature is normal, high, or low. Although infections are usually associated with fever, serious infections, especially in infants and immunocompromised children, may cause hypothermia.
It's important to understand and be able to perform the first two parts of a systematic assessment, the initial impression and the primary assessment. Adhering to these steps allows you to thoroughly evaluate the child's condition, identify any problems, and intervene with the appropriate actions. What you know and do can save a child's life. After the ABCDE primary assessment, an in-depth secondary assessment is performed. You'll be taught the use of a mnemonic to review essential elements of a secondary assessment. In addition to a thorough physical examination, a healthcare provider with Pediatric Advanced Life Support, or PALS training, should gather additional information about the patient and the incident that resulted in the need for medical care. Caregivers, primarily parents, other family members, and babysitters, will generally provide most of the information. The sample mnemonic provides a memory aid to help recall important medical information necessary to provide the best care for your young patients. These topics include signs and symptoms, allergies, medications, past medical history, last meal, and the events leading to the injury or illness.
The sample mnemonic is really helpful because it helps you gather information about a sick child in a systematic manner. S stands for signs and symptoms. A sign is an observation that you, as a healthcare provider, make when assessing a patient, like the patient is wheezing. Examples of these signs include tachypnea, tachycardia, or diaphoresis. A symptom is a problem or complaint that the patient or the patient's caregiver reports to you, such as shortness of breath, abdominal pain, decreased appetite, or headache.
The next thing you want to do is ask about allergies. Are there any known medication and food allergies? What are the associated reactions? Food allergies may affect a child's care. After allergies, ask about medications, including over-the-counter meds, vitamins, herbal supplements. The patient's medications can provide important clues to his or her past medical history and current presentation. If there's a possibility that the child's symptoms are the result of a drug overdose, it is important to ask the caregiver what medications can be found in the child's living environment.
Once you know the child's medications, obtain the past medical history. That includes the child's previous illnesses, hospitalizations, surgeries, and immunizations. Past medical history can often provide insight to the child's current clinical presentation. For instance, a history of coughing at night may suggest asthma as a possible reason for a child's current trouble breathing.
But once you know the medical history, ask about the child's last meal. Knowing when and what the child last ate or drank is important. In cases such as anaphylactic shock, what the child ingested may be the actual cause of the condition. The time that has elapsed between the last meal and presentation of current illness can often dictate treatment and management of the condition. Pediatric emergencies sometimes require surgery, in which case the surgical or anesthesia team will want to know when and what the child last ate or drank.
The final component in the sample review is events, the events leading up to the current presentation. By discussing the events that led to the current doctor's office, ED, or hospital clinic visit, providers may learn important information that can contribute to the child's care. Now, we all know how important it is to treat the injuries in a child who has fallen down the stairs, but we certainly want to know if the fall was caused by a medical problem like a seizure. Healthcare providers should obtain an accurate timeline for all signs, symptoms, and events leading up to the current presentation.